Hello everyone, and thank you for watching Fayetteville Public Utilities Channel 6. I'm Sarah Mack-Young, and in our studio today we have two very special guests with us. From Lincoln Health Systems, we have Miss Debbie Yorba and Miss Debbie Groce. Both are great, wonderful people, and I'm gonna let them tell you why they are here in a minute, and you'll find out real quick. But both work at Lincoln Health Systems, and Miss Debbie Yorba, I will start with you and let you introduce yourself to our viewers at home.
Hello, I'm Debbie Yorba, and I'm the administrator with Lincoln Medical Center, Home Health and Hospice.
And I'm Debbie Groce, and I am the hospice coordinator and admissions nurse at Lincoln Medical Home Health and Hospice.
All right. Ladies, tell the folks at home how long both of you have been with Home Health and Hospice.
Well, with Home Health and Hospice, I've been with our facility in and out for 3 years, working as the administrator, almost a year now. With the health system, I've been here 18 years.
And I have been with Lincoln Medical Home Health and Hospice for about 5.5 years.
All right. So both of these ladies work really, really hard, and they've got a great staff of folks that help them too. And we're going to talk to you a little bit about Lincoln Health Systems Home Health and Hospice today, and kind of educating our viewers at home and letting them know a little bit more about hospice. Sometimes when we hear the word hospice, we think it's not a good thing, but it is a good thing.
It is a good thing.
Very good.
Yes.
So let's talk a little bit. It is November, and November is special for hospice, so I will let you ladies tell why.
Okay, well, hospice is recognized in the month of November, and it's a time that we pay honor to our patients that we see for hospice, and it's a time that we remember our hospice patients that we have taken care of in this month. So one of the things you'll see in the county and at the hospital is a purple light, and it's when we light the sky purple in honor of our patients. So
I absolutely can verify that it is that way. I was there last night and I saw it.
Great.
And it's really cool. Drive by there. I did not know why it was that color, so now we do know.
Yes, it's in honor of those hospice patients that we're currently seeing and those that we have seen before.
All right. So let's talk about why is the color purple? Debbie Groce, tell us why it's purple.
Well, the three hospice colors are purple, green, and gold. And so we've been going with purple to show that.
And does the purple have a certain meaning behind it, or is this just the colors that they chose?
I think it's just the colors.
It's a universal color. All the hospices use it. Many of them are lighting the sky purple across the nation. So, if you drive in different cities, you may see it, and it's being recognized. So,
all right, that's really cool. And we talked a little bit about hospice, and sometimes I think folks get a little nervous when they hear that word. And then we want to tell folks at home, you shouldn't get nervous when you hear that word. It's a wonderful thing, and it's a wonderful something that we want you to take advantage of, and take advantage of it early. And we'll get into talking about that.
We will.
Absolutely. But what are the goals of hospice?
Well, we talked about a negative connotation, and one of the biggest problems is, when a person has been given a life-limited diagnosis, there's a lot of burdens. And so when we come in with hospice, we want to ease those burdens for those patients. And no matter what those burdens are, sometimes it's symptom management, sometimes it's the anxiety of what are we going to do, how are we going to handle that. So when we come in as the hospice team, it's like looking at each patient and how do we ease your burdens. And so that's our biggest goal in hospice, is coming in with those symptom management and working with each patient individually and finding out how do we ease your burdens and how do we work as a team for what works best with each patient.
Absolutely.
Well,
it's about quality. The founder of hospice said that it's about living, but it's okay to die. And that's what we are, is we're about living day to day, moment to moment.
Right.
Absolutely. Lincoln, we're blessed to have Lincoln Health Systems in our community, and what's the reasons, what's one of the benefits to choosing Lincoln Health Systems for home health and hospice?
Well, at Lincoln Medical Home Health and Hospice, our staff is cross-trained. We provide the services of home health and we provide the services of hospice, and all of our nursing staff, clinical staff, are trained to do both home health and they're trained to do both hospice. So when we're working in the home with a home health patient, or we're working and they're maybe wanting hospice but not quite ready for hospice, we can go in and we can provide home health care to them, and we can work with them until they're ready for hospice. And then when they're ready, then our team knows, and then we can just transition them over to the hospice side. And so if we don't have both those benefits and a patient's not ready, then they can't have that. So with our team being cross-trained, they're ready. They know how to work with the family, how to work with the patient. So it makes it a great transition for our families and our patients.
Especially with the fact you keep the same nurse, you keep the same tech. So it's somebody you already know, somebody you already trust, because we're going to be part of a team. So you have to have that trust there.
Right, and that's been one of the biggest things with our families. They don't want to leave one nurse and go to another nurse if they have to change agency, so they keep those same people.
Absolutely. Maybe explain to folks at home a little bit more about home health and what that means, and how you guys help, maybe help them better understand the transition there. Why home health first?
Well, with home health, a patient has to have a skilled service for either a nurse or a therapist to come in, physical therapy, occupational therapy, or speech therapy. Once they have those to come in, then the social worker or the home health aide can come in along with them. A patient has to be homebound to get home health to come in. And so we see them for a short term while we're meeting that skilled service. And once that skilled service is finished, then home health discharges the patient. With hospice, they have to have a life-limited diagnosis, one that's terminal, and they have a 6-month or less life expectancy. They don't have to be homebound. And as Debbie said before, we focus on quality of life, not quantity of life. So we go in with a different outlook. We want the patient to live life to their fullest. And our goal, again, is to ease those burdens and figure out how do we help that patient live what time they have left to their fullest and get the best out of what time they have left. So we just go in with a whole different goal, a whole different angle, and how do we get the best of their life and the best quality.
Absolutely.
We've had the privilege of having a patient have his horse brought to him. Another patient got to go on a horse ride. We had a patient who'd never been to the botanical gardens, and her entire family got to go. We got tickets for that. She also moved up redoing her wedding ceremony and got to see her son married in their home. So we've been part of a great many things, and that's what we're part of, not just helping the physical, but also the emotional, the mental, and the spiritual.
Right.
We try to treat the whole person and the whole family.
Right. So when you look at home health again, home health, we look at the physical. And on hospice, as Debbie said, we look at emotional, spiritual, physical, and mental. Yes. So we look at 4 different aspects. Home health, we look at the patient. On hospice, we look at patient and family.
But the great thing is you're going to get a nurse and you're going to get a tech, and those are going to be the folks that follow with you the whole time.
Absolutely.
Yes.
Not only a nurse and a tech, on the hospice side, you're going to get a social worker, you're going to get a chaplain, we have volunteers, we have a whole team that comes in, and not every patient gets the same. We come in, we have an interdisciplinary team that meets every 2 weeks, and we go, and Debbie does the majority of our admissions, not all of them, but the majority. She comes out and she meets with our families as our hospice coordinators, and sometimes she'll go out and do a consultation first before she even does the admissions, just because families want to just talk about it. And so we go out and just talk and before they make decisions. And after she does that, then we'll schedule an admission if they make a decision that that's what they want to do. And when she admits them, they look at what does this patient and this family need. And so sometimes we admit patients for the families, and sometimes we admit them for the patient, and sometimes we admit them for the patient and the family. Right. It's all different for each individual person.
But it's personalized care for each
personalized
individual.
care for each
very
individual.
Much so.
Absolutely. How do people know when their family member might be ready for hospice?
There's usually some kind of decline. You see them eating less, losing weight, becoming more withdrawn. Maybe they're falling more. Or it comes to a point where the doctors start telling you there's nothing more we can do in this situation. And at that point, or they're just tired, they keep telling you, I don't want to go back to the hospital. I don't think I can handle another visit to the hospital. That's when it's time to come and talk to us. Call us.
They no longer want to seek aggressive treatments.
Yes.
That's a big one. A lot of times people used to think that cancer was the diagnosis for hospice, and it's not that way. I would tell you probably only a third of our patients have cancer. We see a lot of different end-stage cardiac diseases, end-stage respiratory disease. End-stage dementia is a big disease process that we see in our hospice patients. But they no longer want to do anything aggressive. They're tired, like Debbie said, tired of going to the hospital, tired of getting that aggressive treatment, tired of the chemos. They don't want it anymore. And so, again, it's about quality, not, they don't want, it's not about the quantity. So
It's about the quality.
it's about quality.
Absolutely. Can a person that's taking care of someone that may be elderly or someone that does have an aggressive type of something going on in their life, can they get their family members on hospice, or how does that work?
If they have an aggressive disease process going on, then they absolutely, we would come out, we would get a copy of their medical record, and we would review it to see if they meet their certain criteria. We go by Medicare's guidelines because most insurance companies follow Medicare's guidelines, and we review it to make sure that they meet. If they have, we get phone calls sometimes because mama's elderly and they're just getting frail, and can hospice come in? That's not one of Medicare's guidelines. So that one doesn't meet. There has to be a disease process that's going on, that something's going on with them for us to go in for hospice. So the elderly doesn't get it.
Right.
And so, but the disease process with it, it does. And most people have it, but there are some that don't. There are some healthy elderly people out there that don't meet the criteria.
Right.
So,
Understand. How do you decide? You kind of touched on this when we talked about a lot of different folks. It's a team effort in deciding the care that they receive. You talked a little bit, but you said everybody's different, and everybody doesn't in that interdisciplinary team.
It's a big word.
That is a big word. That not everybody gets those same services. They all have a team, but they don't all receive the same services. How do you determine that?
Well, we, like on the admission, Debbie sits down with the family, but it changes sometimes. We have an interdisciplinary team meeting every 2 weeks. We have a great medical director. Dr. Bill Jones is our medical director. He comes every 2 weeks to our meetings, and we sit down and we meet every 2 weeks at our hospice office. And we review every single patient. Pharmacy is involved because we have constant medication changes with our hospice patients so that we can make sure we're meeting their symptom management, whether it's pain management, whether it's breathing problems, whether it's anxiety, depression, whatever it is that's going on. We review all those things, and we talk about what's going on. What needs are they having? Do they need respite care? Does a caregiver need a break that they might need to go to a break where they go to the nursing home for 5 respite cares where they go for 5 days to the nursing home where the caregiver can get a break so they can have rest, and then they come back home. So it's a great opportunity for them to have rest. We have great volunteer programs. We have a group of wonderful volunteers that come in. They provide direct care or indirect care. And direct care is where they actually go to the homes. They help the family members in the homes. They sit with our patients. They don't actually do direct hands-on, but they could sit with the patients while the families can get out of the house and go grocery shopping or go get their hair done or just get out of the house for a little while because the caregivers get tired in the house. Our indirect care volunteers, we've had them build ramps,
mow lawns.
We have them come to the office and do mailings for us for our bereavement program and fill out cards, file in our hospice charts. So our volunteers are a huge asset for our hospice program. They do a lot of wonderful things for us. So.
What makes hospice a unique kind of medicine is that interdisciplinary team means it's a team approach, and by being a team approach we can actually make the patient the center, and we no longer have the disease be the center.
Absolutely.
We shift our focus off the disease and onto the patient themselves and onto what's going on with the individual patient, and we spend a lot of time talking to the patient, talking to the family, talking to the caregivers. What are the needs? What's going on? What's bothering you the most? And what can we do to help? And we just sort of bring our little bag of tricks, is what one patient called it, and see what we can do to help that patient.
Absolutely. And you guys talked about volunteers. And I'm sure you're always looking for more
Always
of
looking
those.
for volunteers.
And so how can folks get involved if they want to volunteer, either directly or indirectly?
Well, they can call us at our office for sure, and we have applications for volunteers, and we take applications for volunteers in the hospice, and we have a volunteer program at our hospital also. So we have a big need for volunteers all the way across, and we will gladly take them. We actually have a volunteer training program for hospice that they have to go through, so it's not as simple as just signing up, and it's not a long volunteer program. They come in for like a half a day and go through we have a volunteer coordinator. Her name is April. She's very energetic and eager to do a lot of things, and she works with our volunteers, and she does the program. Her and our social worker, Brianna, they sit with them and go through the program with them and train them. And then we have meetings quarterly with them, and a lot of work goes into it, and just a part of that training. So, yes. And then find out what that volunteer wants to do, because some people are like, I don't want to go in the homes. This is what I want to do. But the other ones are like, I do want to go in the homes. So,
and some say, well, I just want to go and sit with someone who's dying and hold their hand.
Yes.
Gotcha.
And somebody says, well, I'll mow lawns, or I'll go grocery shopping, or I'll bring food. And we can use any of that.
Any of that.
Absolutely. You guys also touched a little bit about your bereavement program, and that's something that's a part of the hospice. Could y'all touch on that and explain that to folks at home as well?
We can. So, we talked about hospice not being just for the patient, it's for the family. So when a patient passes away, we continue to work with the family for 13 months after the patient passes away. And we follow up with them for that time. We follow with phone calls, we send them cards, we do mailings on things that help them through their grieving process. Annually, we have our butterfly release program. I'll let Debbie talk about that because she's real fond of that. You want to talk a little bit about?
Yeah, we have a saying that what the caterpillar considers the end of life, the Creator calls a butterfly. And so once a year in the spring, we release butterflies in honor of our families. And one of the butterfly releases, I had the honor of getting to release a butterfly shortly after I'd lost a family member, and realizing how really special that was and real positive it is. That, and we get to touch base with our patients. And yes, our bereavement continues for 13 months, but I can tell you it continues for years. There are people from when I first started in hospice that I hug when I see in the store. I still ask how they're doing. They still come out to the butterfly releases and are still in contact with us.
Right. And speaking of that, we're also doing a grief support group. We do it every other week, and we hold it at the community senior citizen building. And our social worker and one of our volunteers do that, talking about what the volunteers do. So that's been a great program. It's every other Friday, and I think we have some, you can call the office and we can give you the exact dates on that. So that's been a great program, and we're looking at advancing that and maybe even offering that over at Donaldson Care Center. So that's some of the things we have coming up. So
absolutely, that's wonderful. Ladies, what's one of the most difficult things that you see in hospice?
It's getting in there and the patient is almost gone, and we can't manage the symptoms. We're fighting to control them. We can't really help the family through because we just got there too late.
Right. And
that's a very hard thing to see.
And I think that happens because people, like you said at the very beginning, people, when they hear the word hospice, it's like, they're afraid of that word. And, one thing we say about hospice is hospice does not postpone death or doesn't hasten death. It does neither. And but people are afraid. They think if we say yes to hospice, that it just like turns up the clock, that it's going to make their time less. And studies have actually shown that when people go with hospice, that sometimes they actually live longer, because when we start controlling the symptoms and giving them better quality of life and reducing their anxiety and their stress, that actually they live a little bit longer. So that's one of the if we can get in there early. But when we get them, when we actually get referrals when we're in there less than 24 hours. And when we do that, as Debbie says, there's not much, all we are is support to the family. There's not much symptom management that we can do. We become the support team to the family. And to me, that's one of the hardest things too. Yes, hospice is meant for when patients have 6 months or less. Now, being said, doctors can't predict that. They can't say for sure a person has 6 months or less. It's based on, if a person with this diagnosis they might have 6 months or less. We've had patients for over a year and a half.
We've had one for 5 years.
For 5 years on hospice. As long as they're showing a continuous decline, they can stay on hospice. We've had patients we've discharged from hospice because they started doing better and they started improving. So we discharged them from hospice and we moved them, transitioned them to home health. So again, it doesn't set the clock to go faster when we put them on hospice, but there's a fear. You say hospice, it's like I've given up, you know, but it's not giving up. It's just like, how can we improve quality of life? How can we ease the burden for the patient and the family member, and what can we do to help? So we're the support team.
And some people are afraid when they sign on that line that it's, I can't go back on this. Once I decide hospice, we can't go backwards. But if things change, if something happens, we can do that. And then we can adjust care to continue for the patient to have quality. We're not going to starve them or drug them to death or anything like that. We want to keep them going so there's a chance that if they do improve, that they could go back.
And that's a big myth, that people think that when they come on hospice is that we just start giving them a lot of drugs and we drug them, and that's not true. We do symptom control, but we don't just give them a lot of drugs to drug them. So that's a myth.
And we kind of touched on this, but it's call early.
Call early, absolutely.
Yes, definitely.
Call early.
So if you remotely, if your family member or yourself has been diagnosed with something and you are told that it is terminal, it is something where you need to go on and start calling and looking and asking questions. Would you agree with that?
Even if you just want questions answered, doesn't mean you're signing and saying I'm going to do it. We're more than glad to come out and answer questions. At least start the questions. So it's a great thing to do. Yes.
Now, this is something I should have asked you at the first of it. How many folks are on your team? How many hospice folks do you?
I think we have close to 20 employees altogether with our part-times and our PRNs. Yes. So we have a team, you know, we talked about our medical director, we have a social worker, volunteer, well, we have more, we've got our 15 volunteers, so that's kind of our employees. We have RNs and we have LPNs and we have our techs. And I forgot, we have therapists, but our therapists mainly work on the home health side, but on occasion we do put a therapy visit on the hospice side, and it depends on what the patient's need is again. Yes. So,
and even our clerical workers are involved. I've had my clerical, I had a patient that's wife couldn't get home when she said she got caught in traffic, and he panicked, and she just talked to him while she was doing her work. And then, so that way, every time his wife had to go somewhere, he'd call her and they would sit and chat.
Yes.
And sometimes they bring to our attention, maybe the family needs a visit sooner than we had planned because they heard something in a voice that just clued them in to say, something's not right there, please make a visit. So our clerical workers are just as involved as our rest of our staff.
And then we have our insurance builder who works with the insurance companies to find out exactly what does their insurance cover, what benefits do they have under insurance. And you know, one time we had a gentleman, had a commercial insurance, didn't cover hospice, but we were able to do home health with the hospice flare, and it was a great benefit. So we're, you know, so that's again the ability to do both sides, you know, so.
Absolutely. Something else I think we might want to talk about, and you know, you talked about your staff. That is a lot of folks, but can someone stay with them 24 hours with hospice, or how does that work?
The type of hospice that we are is we do intermittent visits. So we come in and out, and our nurses and staff are seeing both home health and hospice during the day. So they're going to both during the day, and our nurses will see 5 to 7 visits during the day. If a patient, there's different levels of care in hospice. If a patient got into a crisis where they were out of pain, we could put them on continuous care where we could do up to 8 hours in a 24-hour day. Or if they got into uncontrolled, we could actually go and put them into an acute care setting for what we call general inpatient. And they'd go into either to our skilled care or into the hospital for up to 3 days. But we would not go into the home and stay overnight. A lot of people, when we sign up for hospice, they have this perception that we're going to come in and stay with them. And then they get upset when we're not there continuously, and that's not the service we are. There are hospices that have in-home facilities where people go and stay there for hospice, but not in the home.
Gotcha.
So.
Understand. All right. Is there anything, ladies, that we've forgotten? Anything else that you would like to tell folks at home? You know, we want them to call early. We want them, if they have questions, to call. Absolutely call the office. What is that number again, Debbie?
The office number is 433-8088, and we want everyone to call us your hometown hospice. Yes. We're here for our residents of Lincoln County. We're here to serve you, and it's our honor and our privilege.
Absolutely. I told you these ladies were very special people. Mm-hmm. They do a very special job, so I don't have a problem calling y'all special guests.
Thank you.
What you do is wonderful. We appreciate what you do for our community.
Thank you.
We thank you for coming in and talking to our folks at home about Lincoln Health System's home health and hospice.
Home health and hospice.
And what you do there. We're so thankful.
Thank you.
And we thank you, our viewers, for watching FPU's Channel 6, and we'll see you back in here next time.
Thank you.
Thank you.